My name is Shauna Webster, and I'm the Executive Director of NAPSIS, the Nonprofit Association of Vital Records Offices in all 57 jurisdictions. Our association's mission is to provide national leadership for both vital records and the related information systems in order to establish and protect individual identity and improve population health. So today, we're here with our outstanding partners, March of Dimes, and the Society for Maternal Fetal Medicine to talk about the improving population health side of our mission, and to share with all of you the myriad of ways in which vital records data are used to improve the health of moms and babies. Today, you'll hear a number of stories about how data is turned into action, and why investment in vital records produces really incredible results. Each one of our speakers today will provide you with examples of how much our vital records agencies accomplish every year, or help to accomplish by getting better quality data, more data, to decision makers and faster than ever before. If you're following us on social media, you can join the conversation at #VitalForAreason. And we're also live streaming today on our Twitter feed and Facebook as well. So first, a little bit more about NAPSIS itself and the structure of vital records agencies in the U.S. You may or may not know that the collection of vital records, including information on births, deaths, and other life events, is actually the legal responsibility of the states and not the federal government. Vital records and their data are collected and owned by the states, and access to those records is regulated each by their own individual state laws. And guess what? They're all a little bit different. Surprise, surprise. In most cases, vital records are kept confidential to protect privacy and prevent identity theft. So that's the other side of our mission. But the de-identified vital records become the source for calculating basic statistics on health across the nation, and are also regularly used for medical and health research. So anytime you hear or read a news article that includes health statistics, it's likely that those figures started in vital records. And those statistics help us create targeted, effective public health programs for moms, babies, and families. And maybe even more important, they help us measure the success of those programs. NAPSIS also plays several critical roles in the national vital statistics system as a whole. We manage national electronic systems that allow states to exchange data with each other and with other public health partners like our friends at NCHS. And we provide leadership development and training for our members. We engage in national advocacy efforts like today's that serve to really educate and inform policymakers and partners about the value of vital records and the statistics that they yield. We also play a critical role with other partners, whether they be state agencies, private industry, foundation, or other parts of the federal government. And that's what I want to highlight in my short time here with you today, and how those relationships help to provide you with a sense of how much can be done with a little amount of resources. So first, I want to talk about a project we have called USA Leap. NAPSIS worked on this groundbreaking project with NCHS and the Robert Wood Johnson Foundation and produced the first ever health indicator at the census tract level. To statisticians, this is really exciting stuff. This partnership succeeded in geocoding vital records data to produce life expectancy estimates for over 62,000 census tracts. That's not all of the census tracts, but it is the vast majority of census tracts in the U.S. This is the very first data set of its kind. And it's going to allow city planners, health officials, and policymakers to get a far more detailed picture of how small distances geographically can lead to wide gaps in life expectancy and other equity issues. The release of these estimates generated extensive media coverage at both the national and state level, NPR, the Washington Post, Newsweek produced all articles on these estimates, and 23 states had local media outlets pick it up as well. A real success in terms of communication for public health, which we have to call attention to and champion whenever we can. NAFSIS also provides technical assistance to vital records offices participating in the National Evaluation for the Healthy Start program. And we're on hand to assist vital records offices and or the Healthy Start grantees to address questions and provide guidance on data linkage projects. NAFSIS is also working closely with CDC's own Division of Reproductive Health, a great partner of ours to improve the quality of birth and death data exchange between states. And you're going to hear a lot more about that project when Devin speaks to you a little bit later. So this is what I want to emphasize. Investments Congress has made in the National Vital Statistics System over the past 5 years have really made a huge difference. Between 2012 and 2017, the percentage of mortality files transmitted from the states to NCHS within 10 days of the event increased from 14% in 2012 to 53% in 2017. Huge increase, almost 300%. Thank you, yeah, absolutely. That deserves some applause. So just imagine where we're going to be in 2023 with a little bit more resources at our disposal. These are just a few examples of how valuable these investments can be and how this kind of federal and nonprofit partnership can move the needle for data quality and timeliness. So, without further ado, I want to introduce our guest speakers today. Their bios are included in your folders. You're going to hear first from State Registrar and Director of the Bureau of Vital Records and Statistics in the Louisiana Department of Health and a member of our NAFSIS Board of Directors, Devin George. After that, we'll have Dr. Jeanette Lewis, Associate Professor of the College of Medicine, Obstetrics, and Gynecology at the University of South Florida. She's also on the Board of Directors of the Society for Maternal Fetal Medicine. After her, we'll have Rebecca Russell from our partners at the March of Dimes. She's Senior Director of Applied Research and Evaluation. And last but not least, bringing up the end there is Dr. Lou Sadi, the current NAFSIS President of the Board of Directors, State Registrar of the Office of Vital Statistics in Kansas. Devin, will you join us?
Good morning. Just to kind of start off, death records are that are filed with vital records are used to initially identify potential maternal mortality deaths, which makes the accuracy of these records extremely important. The 2003 revision of the U.S. Standard Death Certificate, which actually was implemented at various times throughout the last 15 years, included what I'm going to call the pregnancy checkbox. For this item, or the pregnancy checkbox, the medical certifier, whether it be a physician, a coroner, or a medical examiner, specifies whether a female was pregnant at the time of death or within 1 year of the death. That information, along with the death record, is filed with the Vital Records Office of that jurisdiction. That information is sent to CDC, National Center for Health Statistics. It is then medically coded with the ICD code and is returned to the jurisdiction with that code. Any kind of inaccuracy of data that's reported on the pregnancy checkbox can lead to over-reporting state and national maternal mortality ratios. So in Louisiana, Vital Records and Maternal and Child Health Program have a very strong relationship, and we're normally working on multiple quality assurance projects or initiatives at the same time. Because of that relationship, we jumped on the chance to partner with CDC Division of Reproductive Health in 2016 to conduct a pilot on to evaluate and assess the data that we were receiving with the pregnancy checkbox on death records. The pilot was done with 4 states and the Division of Reproductive Health. Louisiana was one state. The other states were Georgia, Michigan, and Ohio. For the pilot, each state kind of designed their own QA workflow and how things would work. And it was amazingly similar. It was interesting at how similar those QA workflows were for each one of the states, which shows that it can be easily replicated nationwide. The jurisdictions also use a standard data capture tool just so we could track this and track the results of the pilot project. And basically the main 3 topics or action areas for all of the state's QA workflows was basically data linkage, follow-up, and correction. Now, what we found in Louisiana as we went through this is we would keep hitting this. We would initially work with our maternal child health program. We would try to link any female death certificates where the pregnancy checkbox said that she was not pregnant at the time of death. So we would try to link those records with a birth or fetal death. Doing that, we found 12 deaths that were where the female was pregnant at the time of death or within 1 year of the death that was not reported to us. So those 12 would have been missed potential maternal mortality deaths. In addition to that, for the records that we received in where that pregnancy checkbox was checked that she was pregnant or pregnant within the past year, we had 78 records in 2016 that indicated that. We would then try to link those records with a birth or a fetal death record to validate that the female was actually pregnant at the time of death or within the 1 year. With doing that, our MCH regional coordinators would try to, for the non-validated records, our MCH regional coordinators would go and try to abstract medical records to determine whether the pregnancy checkbox was valid or not. Then we would in turn make the corrections on the death record and also provide that information to NCHS, and it would update our state file as well. So we had, including the 12 records that we found that were indicated no pregnancy, we had 91 potential maternal mortality deaths that were identified using these methods. Of those, 33 had the correct pregnancy checkbox selection indicated. 33 out of 91. 58 had the incorrect pregnancy checkbox indicated. That's 64% of the records that we had that potentially showed a maternal death were inaccurate. 55 of those, 58, were due because there was no documentation and the female was not pregnant and had not been pregnant within that 1 year. 3 were due to the incorrect timing that was of that, the birth or the fetal death. So we took this project, and this is now part of our permanent workflow. This is something that we feel very strongly about based on the results that we got, and we now do this have done this as a permanent workflow between maternal child health and vital records in Louisiana. We'll continue this. We did it in 2017. We're doing it now in 2018. And our goal is to identify the correct pregnancy checkbox errors at the state level before the state and national statistical files are finalized. We're also, because of some of the results of what we found, we're also changing our electronic death registration system to include more validations or other edits to prompt the certifier, whether it's the physician, coroner, or medical examiner, are you sure this woman was pregnant, at the time of death? We feel like all these actions are being done as a result of this pilot project that we did with the Division of Reproductive Health. And these results were not just Louisiana specific. I was talking about Louisiana, but each state that participated in this pilot had very, very similar results, which shows how that pregnancy checkbox and the accuracy of it can inflate potentially the maternal mortality rates that we're seeing in the country.
Thank you. As was expressed, my name is Judette Lewis, and I am representing the Society for Maternal Fetal Medicine, and I would like to talk to you a little bit about how the data gets translated into practice. So the first question is, what is a maternal fetal medicine physician? These are physicians who, after undergoing 4 years of medical school, trained for 4 years in obstetrics and gynecology, and then they decided that wasn't enough, or they're putting off the real world for a little bit longer. So they do an extra 3 years of training in just how to take care of pregnant moms and their babies. So when you look at what we do as maternal fetal medicine physicians, it could be taking care of women who came into pregnancy healthy, but then got sick or developed a complication, or it could be moms who started pregnancy sick and needed extra care. But we also are uniquely qualified to take care of their fetuses. No one else trains in how to take care of babies when they're in utero. So when you look at what a maternal fetal medicine physician does, I like to think of us as superheroes, because quite frankly, who wouldn't want to be a superhero? But we're also recognizing that our role should be more than that it shouldn't be just dealing with the acute emergency, but that we also have a role in making sure that moms stay healthy for the rest of their lives and also come into the next pregnancy healthier. And that's where data helps us. The other tool we have to help us is the Society for Maternal Fetal Medicine. That's our organization that provides support for us in terms of basically giving us tools with which we can use to get information out to the other physicians and the healthcare professionals who take care of pregnant women about what is the right way to manage these women who have complications. The Society for Maternal Fetal Medicine also fights for us in terms of those legislations that will help our cause and things that are important to us, but then also providing knowledge and research to everyone. So when it comes to maternal mortality, we're talking about the death of a woman while she's pregnant or within 1 year of pregnancy. It's irrespective of the duration of that pregnancy or the site of the pregnancy. And it could be from any cause that's related or aggravated by the pregnancy, but certainly it doesn't include accidents or incidental causes. And that's important for us to basically delineate, because we want to focus on those things that are truly related to the health of the woman and could not, and not things that were incidental. It's important to know that in the US, the rates are rising, the rates of maternal deaths are rising, and it's surprising considering how much money we spend on healthcare, period. But also important to the people who practice maternal fetal medicine is the fact that there are large disparities. And we all agree that whether or not you survive childbirth should not depend on where you live. And that's urban versus rural, or it should not depend on your race or ethnicity. And in this country, it does appear to be related to that. In terms of these committees, what they do is basically on a state level say, we're going to review every maternal death. We're going to use whatever data we have, not just vital statistics, but actually review the case, get the records, and see what happened so that we can figure out why this woman died, what were the contributing factors, and what were the gaps in her care that could have contributed to what happened. There's very much a need to make sure that that process is standardized everywhere so that you're gathering all of the same information, so you're comparing apples to apples. But then when you get that information, what's very important is what you do with it next. And what we have been able to do is to say, well, these are the top causes, these are the things that are going wrong, and this is how we're going to intervene. And so much like the aviation system, we can use things like checklists to say, well, this went wrong because someone missed a couple of steps, and so here's a checklist to remind you that if you're encountering this scenario again, you need to do all of these things to make sure that this woman is properly cared for. There are also bundles, which are just simply a bunch of things that need to happen together if you're taking care of a certain condition. Again, it prompts people to be, to remember all of the steps. And, someone who's a little bit more utopian may say, why wouldn't, someone remember all of the steps? Well, a lot of these causes of death are uncommon occurrences that, yes, for most people, pregnancy still is a safe and benign, although painful, messy process. So for most of the time it goes well. But when it doesn't go well, you sometimes do need a prompt and a reminder of what are all of these, the proper steps to undertake so you can actually improve the outcomes. So these reviews are part of a greater system, right? So we do the reviews, we get the information. That information can then be sort of a tool for the perinatal quality collaboratives so that they know what to target. Perinatal quality collaboratives are just groups of people who have the common goal of improving outcomes for moms and babies, and they include nurses, physicians, social workers, public health professionals, just really anyone who can fit under that umbrella of perinatal care. And they put together these initiatives so that they can help people in hospitals as well as clinics to take care of these pregnancies in the right way. The other person who comes into play is the Alliance for Innovation on Maternal Health, and they likewise are a large organization of people from multiple disciplines who come together and put together guidelines that then they help get out to the practicing providers so that they have information on the right way to manage these people. So just to give you a little bit from the state of Florida, where I'm from, on how we're doing in terms of maternal mortality and what we're doing about it. So as you see up there, we rank number 36, nothing to be proud of. I can be proud of our beaches, but not this. But we recognize that it is a problem. And we have a lot of interest and passion about trying to improve healthcare for women there. So we currently have maternal mortality reviews, and we've had them for some time, and they're funded not just by the state, but also private organizations and the American College of Obstetricians and Gynecologists. All of them work together so that they can review every death of a mom, and they try to do it in a timely fashion after which it has occurred. And people who participate are basically volunteers. They don't get paid for it, and in fact, they pay for their own travel so that they can get to these meetings. If you look at our data over the past years, I think it's important to note a couple of things. That when you look at the overall mortality rate, which is the line in black, that we're at the lowest rate that we've been in a number of years. But I think also important to note is that gap, that in green are non-Hispanic whites, in blue are non-Hispanic blacks. And we're looking at it's not enough to just reduce that rate. Yes, we're at the lowest rate we've been, but look at that gap. There's still a huge gap. And so part of our goal is also decreasing that gap because, again, as I said, who you are should not determine whether or not you survive childbirth. So what do we do with that data? When we get the information from those reviews, we basically get the information out to the providers so that they know something, they know what did we find in the data and what are the areas that they should be focusing on. So they get newsletters, they get alerts if anything urgent is going on. They get letters sent to the hospitals so that the hospitals know what the top causes of death were and what they can do about it. And they actually publish their findings also in the literature. The Florida Perinatal Quality Collaborative is a statewide partnership that was started in 2010. Currently, we have 2/3 of all of Florida's births are covered under our collaborative, meaning they partake in our initiatives. And basically what we do is we focus on the data from the committees to tell us what are the top causes of deaths, and then we come up with these initiatives that provide the people caring for these women with tools so that they can improve how they manage them. So just to give you an example, these were our top causes of death: hemorrhage and hypertensive disorders. So we decided we're going to focus on those two conditions. This is a busy slide, but this was data from our hemorrhage initiative. So OHI stands for Obstetric Hemorrhage Initiative. And what we did was say, we know hemorrhage is the top cause of death. We asked hospitals to volunteer to enroll in this program where we taught them how to identify hemorrhage, because you can't fix what you don't identify, how to manage them, and then also how to prevent them. And so we wanted to know what percentage of the hospitals were even identifying patients who were at risk for hemorrhage. And so in green are the hospitals that said that 75 to 100% of all of the women who gave birth were assessed for their risk. By the end of our initiative, you saw that green bar increase substantially, where there were a lot more hospitals that were assessing almost every patient that came into their system. So again, showing that if you target something and you give them a way to work towards it, that the hospitals definitely could improve. Well, what about their measurement of blood loss, right? It sounds like a no-brainer. How come we don't measure blood loss? Well, typically we do what we call an estimated blood loss, meaning we look at it and we say, oh, we think it's this much blood loss. But there are actually ways to quantify the blood loss, because again, if you quantify it appropriately, then you know when to intervene, when to step up your treatment, or even when the patient may need a blood transfusion. At the start of the initiative, only 4% were quantifying the blood loss for vaginal deliveries. By the end, 62%. So again, we saw change. To move over to a different initiative we did was the hypertension initiative. Hypertension remains one of the top causes of maternal death, in part because their hypertension is not being treated quickly enough, and we know that the hypertension should be treated within 1 hour. So we looked at baseline before our initiative. Only 7% of the hospitals were treating all of their patients within 1 hour. By the time we ended the initiative, 63% were treating them appropriately. So it's not the 100%. And you know, there's no intervention that you're ever going to do that will give you 100%. But again, it shows that if we focus on something, we can at least make some strides. We can educate the hospitals and their staff about the appropriate way to treat these patients. But also important is the education of patients. Because truly, most of the time when women die, they don't die during that same, admission where they delivered their baby. A lot of them go home and they have symptoms and they're worried about their babies, and so they're ignoring their own symptoms, or their family members are telling them, oh no, that's fine, you're supposed to be tired, you're supposed to have a headache, and they listen to them and they don't come back and get care soon enough. Or they reach out and call their doctor and their doctor doesn't listen to them. There are a lot of things that go on, but we realize that that's the most important time period so that they know when to come back in. So for part of this initiative, we ask the hospitals to actually give the patients discharge education so that they know when to come back for help. And so again, in the beginning, only 26% of the hospitals had most of their patients getting it. By the end, 92%. So our initiatives were doing what they were meant to do, to make sure everyone knew the right thing to do. But again, we could only do that if we get data, and the data has to come from all of the states, not just the few who have decided that it is important to them. So once we get accurate data, we can work on this more closely. The Society for Maternal Fetal Medicine is also working on it. This is an example of a fact sheet that we're trying to get for each state. We did not come up with these rankings. We're using existing rankings out there, but the point is that we want each person to be empowered and to know what their state is doing to help decrease maternal mortality. There are these 4 key things that we think are important to decreasing maternal mortalities, and that includes things like having the review committees, because that's an important first step, having perinatal quality collaboratives, which most states have them by now, but also reporting the rates by race, because you can't affect the disparity if you don't know that it exists. And of course, Medicaid expansion, which would help cover more births across the country. And I just want to give a quick example of how having that data also helped us on a local level, where when we were looking at hemorrhages, and we saw a huge disparity where if you had a hemorrhage, if you were Black, you were 4 times as likely to need a blood transfusion. And when we took a deep dive into that data, we saw they were being treated the same way. They received treatment in a timely fashion, they were identified, but that the actual difference was that they were coming into the hospital more anemic than their counterparts. So if I had started an intervention based on the hospital, it would not have cured that disparity, because I wasn't really getting to the right problem. So again, the data helps you get to the right problem so that your interventions are effective. So what we're asking is for support for any of these legislations that will help us reduce maternal mortality, but the first step in particular is this legislative bill that will actually make it easier for states to collect their own data. Thank you.
Good afternoon, everyone. I'm Becky Russell. I am far from a superhero like Dr. Lewis, but I would consider myself a super data user. So I'm really thrilled to see so many of you here today to talk about such an important topic. It is my honor and pleasure to be here to speak to the importance of vital statistics to maternal and child health, and to discuss how we at the March of Dimes rely on those data to help us achieve our mission. I've been at the March of Dimes for nearly 20 years, and it's I've really seen some remarkable enhancements and improvements to the vital statistics system over those years, and it's wonderful to be able to think about where it could go and how important it is that it go there. For those of you who might not be familiar with the March of Dimes, the mission at the March of Dimes is to lead the fight for the health of all moms and babies. We are a unique collaboration of scientists, clinicians, parents, maternal and child health experts, community organizations, members of the business community. We have volunteers all over the country, and staff that are affiliated with offices representing every state, the District of Columbia, and Puerto Rico. As Senior Director of Applied Research and Evaluation, I am responsible for providing the organization with the data, evidence, and expertise so that our staff can advocate for better health for moms and babies, so that we can evaluate and improve our public health programs, to identify and target areas and populations at high risk in order to improve equity in birth outcomes, and to communicate our mission story. My job would be impossible without the vital statistics system in this country. Moms and babies need a champion, and right now, they need one more than ever. We have an urgent crisis facing moms and babies: increasing rates of maternal mortality and severe maternal morbidity, increasing rates of preterm birth. The opioid epidemic and threats from emerging diseases like Zika threaten the lives of moms and babies everywhere. In order to protect the next generation, ensure that every mom and baby has access to necessary care, and work towards achieving equity in these outcomes, we need strong, reliable, and timely public health data sources. The March of Dimes Perinatal Data Center relies heavily on data from the Vital Statistics Program, specifically the birth certificate data and the linked birth infant death data, which combines birth and death certificates for all deaths that occur during the first year of life. And we use these data to conduct analyses to advance our understanding of trends and monitor the health of moms and babies. We also serve the public by providing easy and free access to these maternal and child health data. And these data can be used by program planners, policymakers, researchers, academics, and others interested in perinatal health to advance program planning and informed decision making. Through PeriStats, which is a free publicly available website available at marchofdimes.org/peristats, the Perinatal Data Center provides the public with access to aggregated data from multiple federal and national agencies and organizations. Through a process involving NAPSIS and the National Center for Health Statistics, we obtain approval and are granted access to natality, linked birth infant death data, and fetal death data that include identifiers for states and counties, so that we can then aggregate these data on perinatal outcomes and provide data on both outcomes and risk factors for nearly every county in the United States. These data help illustrate the wide geographic disparities in these outcomes. Taking these data that are provided through our agreements with NAPSIS and NCHS, we provide simple access to these detailed data sets. So while I am a self-proclaimed data geek. I love p-values, I love regression analysis. I realize that the general public aren't. And so being able to have quick and easy access to these data that are available through maps, tables, charts, graphs, at a touch of a button to download them, I think is really quite a remarkable service, and something that can help the staff at the March of Dimes, health professionals, researchers, and students, and it will give them the ability to better understand and describe disparities in poor birth outcomes and inform targeted maternal and child health programming and implementation. The Perinatal Data Center also uses vital statistics data to produce nationally recognized data products that are used both by the organization and our partners nationally and locally to raise awareness, build partnerships, and affect change in maternal and child health. Topics ranging from premature birth to birth defects and access to maternity care, we use vital statistics data to address important issues and engage stakeholders to help us find solutions and improve health. One example of this is the March of Dimes Premature Birth Report Card. Since 2008, the March of Dimes has published this report card to spur action by stakeholders on evidence-based interventions and advocacy priorities to reduce preterm birth, which is a birth that happens before the 37th completed week of pregnancy. We publish these report cards annually for all 50 states, the District of Columbia, Puerto Rico, and the US. These report cards are rich with vital statistics data, including state and county-specific preterm birth rates and indicators of racial and ethnic disparities in preterm birth. These state preterm birth rates are used to assess a state's progress towards reaching our ambitious goal of reducing the preterm birth rate to 8.1% by 2020. In 2017, using 2016 final natality data, 4 states had achieved our 2020 goal of a preterm birth rate of 8.1 and received an A on their report card. This report card generates national and local media coverage, which last year resulted in over 1,900 media hits and 60 million impressions. The 2018 report cards will be released next week on November 1st and will highlight the recent increases in preterm birth rates and the increasing racial and ethnic disparities. Together with our partners and collaborators across the country, we will use this report to amplify our messages, activate stakeholders, and raise public awareness of the seriousness of prematurity. We will be sharing with your offices links to the report and other resources, and we hope that you will all join us in sharing these through social media. As a community, we can create and implement solutions to address these rising rates and help achieve equity in these outcomes for all moms and babies. Earlier this month, March of Dimes released a new report entitled Nowhere to Go: Maternity Care Deserts Across the U.S. In this report, we investigated maternity care deserts, or areas in which access to care is limited or absent, either through lack of services or barriers to a woman's ability to access that care. This report begins to identify these areas by looking at the availability of hospitals, healthcare providers, and a means to pay for that care through health insurance. The report found that more than 5 million women live in these so-called deserts, and that nearly 150,000 babies were born to women living in these counties. Being able to use vital statistics data alongside data from the Census Bureau and the Health Resources and Services Administration, along with other national organizations and agencies, helps us to understand the scope of these limited access areas and the potential impact on outcomes. One aspect of access to care is the ability of women to afford that care and the availability of health insurance. This map shows differences across the country and the percentage of births that were covered by Medicaid. And these data are collected on the birth certificate and are included in the natality file released by the National Center for Health Statistics. Understanding how these rates of coverage differ within and among states can help us to determine effective strategies to improving access through such programs. And I just want to end with a comment that it's important to remember that these vital statistics are not just numbers. While I said I love data, I think they're powerful, I think they are impactful, and I think they can motivate change. These data and these systems capture the stories of real people. The twins born 10 weeks early who spend 6 weeks in the NICU before their parents can take them home. The baby born with a birth defect who doesn't survive to celebrate his first birthday. The new mom who develops preeclampsia after her delivery and can't get to the doctor in time to treat the life-threatening condition. We need to invest in these vital statistics systems so that we as public health professionals can quickly and accurately look at these data. To tell the collective story of the 4 million babies born every year, the 380,000 of them that are born too early, the 700 women who die from pregnancy-related conditions. Telling their stories will help us understand the causes, find solutions, and target appropriate interventions to improve maternal and infant child health. Hopefully one day, all the stories told in these data will have happy endings. But until then, we have to have the data to be able to help us get there. Thank you for this opportunity and for calling attention to this critically important issue. I look forward to identifying ways for the March of Dimes to continue to support the vital statistics system in this country, which provides such an incredibly important tool in our fight to improve the health of every mom and baby.
Okay, I get to use a little bit of what everybody talked about. I appreciate that opportunity. Again, my name is Lou Sadi. I'm the president of NAFSIS and state registrar for the state of Kansas. And I really appreciate what you said about our statistics tell stories. One of my taglines for my bureau is that we're seeing people in the numbers, and it's really important for us to understand that there are people in the numbers. What you've heard is information that's presented to you related to how the data gets used, how we collect it, but what I want to share with you are some salient points about our vital statistics system, and the reason we're here with you today is to try to get you some information to help us understand and how we can understand what happens with what we do in our work, and to help us do better at communicating and educating and informing and empowering people on using our information. There are thousands of us in the vital statistics system in the states at the local levels collecting this data for you. We have a civil registration system that was established in the early 1900s for our citizenry, and it's evolved into a very robust public health information system. That hasn't happened magically. It has, frankly, been the work of maternal and child health directors and those who are doing research and evaluating the state of maternal and child health in this country that really push the envelope and assuring that we get good information from our birth and death systems. We are, I will say, at the mercy of those that report the data to us. Don't want to scare anybody, those of you that use our information, but we struggle daily to acquire this information from physicians who sign death certificates, from birth clerks who fill out the birth certificates for us. We're at their mercy to give us the best information that we can get. We struggle every day with coroners that, in particular, I'll just talk about Kansas, and I know these are not unique stories. I've got a coroner who says, I don't want to provide you opioid or drug information on the death certificate. I don't work for the government, although he takes a check from a county government, but I'm interested in preserving the interests of the family. They don't want to see all those drugs on the death certificate. That's a problem, and that's something we have to do to improve that situation, because as we know, if we don't have the drugs on the death certificate, we really don't have good information about how people are dying. The maternal mortality program and the projects that are underway to improve our information, like Devin spoke about, the information that's collected, pregnancy checkbox or whatever mechanism we use, it is so critical. It's a shame for us to have maternal mortality in this country. It's a sentinel failure of public health to have maternal deaths. And I have to say again, our maternal and child health directors and their partners with, like March of Dimes, and the researchers with the fetal maternal fetal and maternal medicine groups, they're critical for us to be able to demonstrate the problems that we're seeing. But those of us at this level, the level of us in the vital statistics, vital records area, the missing thing sometimes that we don't see is we know our data gets used, we hope our data gets used, but we don't really have those pearls where we can actually say that our data was used to actually pass legislation. We know our data saves lives. We know our data gets used to educate physicians on how to do things better. But we don't really, that doesn't come back to us very, very readily. And it's very painful for us to understand, to grab at those and try to use those to promote improvements in the vital records, vital statistics system. And we're at a level where we need that assistance from all levels of our government, because we know all levels of government are using our information. Let me just share a couple of examples where, and we're talking the last 10 years, some of these things that have evolved for Kansas. And Kansas, the most crimson of states. I'm just saying it's crimson, not just red. It's really bleeding. There's just a huge dislike for mandate, like a lot of states have. It's an evil, dirty word, but sometimes you can overcome those kinds of impressions. So I've been in this position, or at least at the State Health Department, for 30 years. I've seen maternal and child health directors come and go. I've seen varying levels of working together with the partnerships with our coalitions, et cetera. And so we have one now that is really outstanding. And when that person first came to be with our agency, she was actually getting her master's degree in early childhood education, but she was also working in the child care arena. And she noticed, and we shared data with her, that children were dying in unregulated child care facilities, child care homes at a huge rate. Inspected, licensed child care centers had 0 deaths. It's unacceptable for us to have that. So she went to work working with her champions. Unfortunately, the champion that helped us work on this issue had a child that was lost and had died in a home daycare. It was very unfortunate because, you know, you have legislators that make comments like, well, the numbers aren't that high. That poor woman that had to testify pretty much said, well, what it was, if it were your child or grandchild that died, is that a number enough for you? Luckily, they were able to pass legislation, and again, they used our data to help forward this conversation to be able to get all home daycares licensed and inspected by the state. Now, East Coast, West Coast, that might not be a big thing, but for us it was a huge thing. Because you're really trying to manage the forces of mom and apple pie, the safety of your children with the right to own a business and manage that business unfettered. And that's really huge for a lot of our red states. But we were able to overcome and prevail in assuring that the safety of children was much more important. Subsequently, this same maternal and child health director, along with her partners, was able to push statutory requirements for safe sleep. We still had daycare providers putting children on water beds. Totally not allowed. Children suffocating, etc. That provision was put into statute, not regulation. So it is a huge change and improvement for us. And then finally, after educating our legislators, we've got a full maternal mortality review process put together, and we appreciate the work of the March of Dimes to help us get that. That required physicians to actually provide information to us about those. That was that was a heavy lift for us, because physicians don't want you looking at what's being done. But at least we were able to prevail on that and get that particular piece of legislation passed. So that's the public policy side, the state government side, where we're able to capture the information and that's used to forward public policy. We have also participated, and I want to see more of this happen, where we have linked our birth data, for example, with data from a private employer. That employer paid a vendor extra money to assure that good prenatal care was given to their employees. Once we worked through all the confidentiality issues, because my goal was to make sure that they couldn't pinpoint a particular employee for whatever they would like to pick on them about. Once we got that put together, they were able to see that some of the prenatal care provisions that the vendor was on the hook for didn't happen. They had some moms smoking. They had some moms not following up with their appointments like they paid extra to have done. So they used that information, I'm sure, in their contracting process later. But at least it showed them that there is data there that can be used to improve the care that they pay for. So you've heard about some of our improvements that we've made in the timeliness. We're definitely working on quality to improve the vital statistics system, but we still are going to need your help in educating our legislators, our congressmen, whoever will listen to us, to forward some of the needs that we have to continue to improve the vital statistics system. There's a lot of opportunity through the high-tech provisions with now electronic health records that are in facilities now. A lot of projects are underway through the National Center for Health Statistics and other entities to try to acquire this information, pull it out using the technology from electronic health records to make the information richer and more relevant. But states can't manage the funding for some of that. We're going to need your help to help us understand, to help us acquire those resources at some point. The other thing that we're going to be needing, and it's really difficult for us to do, is to understand what kinds of ways we can share information with our policymakers. They're over-communicated to. They probably get lost in the amount of information that's provided to them. How do we punch through with making information that really captures their attention? We're developing systems now that we could be able to merge data, link data, GIS it to death, however you want to do. We've even produced some statistics by legislative district. So if they're going to make a decision on Medicaid policy in their particular district, they can see how many moms they're affecting or who they're affecting. That kind of level of very personal information, I think, can be powerful. But we need some help in communicating that, and we need to understand what works. And that's what doesn't get filtered back to us. As was mentioned with Becky and Dr. Lewis, you know, there are a lot of data geeks out there. We're in that world, but to pull it up to a higher level and understand what you would need to actually communicate, to develop knowledge that will improve our health and save lives, we need your help to help us understand that. So in closing, we want to thank you for all the work that you're doing to help us understand better and to use our information, use our data. You've seen all these tools that are available. Please do that, but also let us know. NAVSIS is available, any of us in our jurisdictions. If you need your birth certificate, call up and say, thanks for doing what you do. We need to hear that. And it's certainly a community that's ready to help make sure that we keep our citizenry healthy and our information flowing. So anyway, thank you.
Thank you, Lou, and to all of our speakers. I'm going to stand so I can see hands. We're going to go into a short Q&A session. So let's get the ball rolling. Yes, ma'am.
So that was done by our regional MCH coordinators who would actually go out. So for those that would not link to a birth or fetal death, those regional coordinators would go out, abstract medical records, abstract everything they could find to try to find out, like, for instance, if it was a miscarriage or, or if there wasn't a pregnancy. There was no evidence of pregnancy. So either way, they would go out there, they would try to get that information from abstract.
Yes.
Hi, I see that there's this congressional caucus on maternity. Beyond that, what are the top action items that should be passing along to our caucus?
It's a great question. I mean, I think funding for the National Center for Health Statistics, they help pass along funding to the states on a regular basis. And I don't think they've seen, we've at least been level funded, but we haven't seen an increase in five years at least. And as we start relying on these national electronic systems to provide all of our partners with almost real-time data, right, for surveillance purposes, for the public health purposes. Better, faster data means better, bigger, faster electronic systems, and they are not cheap. They aren't, and it's a huge lift for individual states. Most of them end up raising the money and paying for them in-house. They are usually not paid for by the feds or any other partner. And that's a pretty huge burden to place on, a very small part of what's normally, a public health office in a state jurisdiction. So I think funding is number one, absolutely. And drawing attention to the real data, I think, is also a really valuable ask. It's very easy to, especially in our news cycle right now, to grab onto what's said and just take it as the word. But as you've heard, like some of these maternal mortality news stories are, not accurate at all. And so the question becomes, we need to be relying on and using the right data. And the right data is the vital records data, right? Because it comes from the source. Yes?
Just real quickly, I'm Anna from Jamie Brewer and Butler's office, and I'll just add to that, HR 1318 was on one of the slides.
Yep.
We'd love to have all of your
More support.
join the bill. Debbie's also here from Congressman Brogo-Aller's office, and our boss is co-chair of the Maternity Care Caucus. So again, just a shout out to that. We'd love to have you join. But we're here to chat about what you're doing too. Thank you.
Thank you. Yeah, Jonathan, you had your hand up.
Yeah, first, thank you. It's a very fascinating presentation. I had two questions for Dr. Lewis. So one, the facts and figures sheet that you alluded to, is that complete for the states? If not, how many of them are available is the first question. The second one, for the interventions that you identified, was there any follow-up done to determine if those interventions have been operationalized and if those percentages were still consistent or improved or dropped in any way?
Okay, so, is this on? I'll answer the second question first. That yes, as part of those initiatives, we would go in and do site visits. We had them report certain metrics, and so none of the sites ever operationalized 100% of everything. But they all did better, and we also gave out awards to top sites who operationalized most things. The best example that we have of it working is the state of California. California is a leader in this. They implemented these initiatives a long time ago, and they substantially reduced their maternal mortality rates. In fact, they rank #1 in the country for having the lowest maternal mortality rate. And you figure that's a large state with a lot of high-risk pregnancies, but yet they were able to do it in part using these tools of reviewing every single maternal death and then implementing these initiatives. So we think it does work, and there are other states that are also leaders in this. New York has made a lot of progress. North Carolina, Illinois actually came after us and they learned from us, but a lot of states are doing these things now. But again, you need the data. To answer your first question about whether these fact sheets are up live, not yet. The person responsible is right behind you in the white jacket. Hi, Katie Shooter.
Very, very soon, and we will be sharing all of this information with our partners and our members as well to sort of explain exactly what people are looking at. So very, very soon.
Thank you. I had that exact same question, Jonathan, so thank you for asking it. Yes, ma'am.
Hi. So, first of all, I've written down statistics. I didn't get quite all of it, but you mentioned that the timeliness had gone from 14 to 43% for the space. That was in how many days?
10 days.
10 days. Okay.
So the event is reported within 10 days.
Okay, great. And then what are some measures you think that states can do in order to improve timeliness?
That's a great question. So one of the things we've focused on the past couple of years that has made a huge difference in those numbers is the implementation of electronic death reporting systems. Again, those big, giant, expensive electronic systems. They really move the dial in terms of not only timeliness, but quality. We've still got a handful of states who do not have an electronic death registration system. In some cases, it's not about money. It's about state IT system, when they're upgrading their system, they just can't do it yet, political will. There's a number of reasons, and they're not always financial. If it were just financial, we'd definitely just throw money at it and have it be done. But it gets complicated. So having electronic death and birth registration systems, they're two separate systems that each jurisdiction has or should have. And being able to upgrade those systems, we've spent the last, I don't know, almost 10 years now implementing EDRS and EBRS in all of the states. And it's at the point now where our IT folks are saying, I don't know, that code is really old. I'm not sure I want that on my system anymore. And so we're, again, like we're at the point now where we're having to rebuild them, do the enhancement, do the big upgrade. And states really need help with that. They really need help with that lift.
And are there any, I guess, special costs, or not costs, but like ways to help states with really high maternal mortality rates? I feel like maybe that could help if they were able to report faster.
Yeah, I'm going to throw that one to the panel. They are our state experts. What could help most at the state level to improve maternal mortality rates?
I think each state is going to be different as far as what's really at the foundation of those rising rates and the high rates. So each state's going to be a little bit different, and it could be anything from legislation to funding for a certain initiative to target something that's going to actually affect that change. So I mean, I would say like it's almost like a specific to the state and the reason, the underlying reasons why that rate is so high.
Right, and having the resources to roll out this pilot to more than 4 states would be a great start, right? I mean, it's a great partnership with DRH, and if we could do it in every state tomorrow, we'd do it right away, because obviously, it points to the problems immediately. Dr. Lewis.
Yeah, not to sound like I have a one-track mind, but again, back to the data collection, right? So, the bill that supports that, making it easier for each state to collect their own data, because I 100% agree that it differs by state. We were surprised to find in Florida that it was still hemorrhage and hypertension. In California, the top cause of maternal mortality is heart disease. So again, the interventions are going to be different depending on what's the top cause. You know, in some places it's opioids. So you need to get back to the data. So I think supporting that piece of legislation that will help make it easier for states to get their own data. And then the next piece is supporting these perinatal quality collaboratives, because they're actually using the data to then go in and make changes. We were lucky in that the CDC put a lot of money into this, but that was the director, the then director, who decided to do that. With the next director, that may not happen, and so I think funding those initiatives will help.
Lou, did you have any? Did either of you want to?
I think one of, can you hear me?
Yeah.
Okay. I think one of the things that would help, the physician community needs to pay attention to how the care is being provided and the importance of the documentation of the procedures, but also reporting to us in the death certificates and assuring that they're completing things properly. It'd be really good if CMS and CDC and others could work together well to convey that. We all know that funding and money talks to providers. We think there's some mechanisms that could be considered, or at least I better say I think there are, but some opportunities that could help physicians realize the importance of what they do, how they document, how they complete death certificates, how they complete any of the documentation to assure that things are properly documented and reported. That would go a long way. And then paying attention to how they take care of the moms, I think, is just huge. It's just really unfortunate that we're at this point.
Yep.
Can I just add to that?
Absolutely.
I mean, again, starts with the data. You have to have the data to know what are the causes of the maternal mortality, and then, you know, that access to care, you know, the availability of that care, working with the physicians, the doctors, the nurses, the midwives. That's one piece of it. But having that data to identify what are the barriers to a woman accessing that care that might be beyond the medical system. You know, I've seen some figures that say 60% of maternal deaths are preventable. You know, a large proportion of them happening after the woman leaves the hospital. And so what systems of care are in place and how do we support those women, you know, are all really important, but it has to start with the data so that we know where they're happening, what are the causes, and then we can really start to look at what are the barriers to accessing that care.
And I would just add, not that I think this is rampant and, you know, within our system, but we've all, at our level, Devin and the DC team and others, we've had those issues where a doctor might tell us, you know, our vital records team will call up and say, cardiac arrest is not good enough to tell us how this person died. Well, we get pushback. It's not my job, or I don't get paid to do this. That really shouldn't happen. And I don't know, like I said, if they could get 50 cents to fill out a death record, maybe that would pay, you know, raise their opinion. I don't know. It's just very frustrating. But those are the things that we battle all the time. And I have an administrative assistants that are calling up physicians and saying, you didn't put enough information on here, and you can imagine how well or how not so well that's happening and getting more information. So there's some paradigm shifts that have to happen in the value of what's being reported on these records.
Can I add to that too? You know, one of the things that DC had done in the previous medical examiner is actually to have CEU credits for how to complete a properly a death certificate, because that's set, you know, from that point of view, it's seldom ever taught in medical school. So there, a lot of times it's the residents who are coming out and filling out the death certificate, and you're trying to reach back to them and say, well, you know, our medical examiner is not accepting this as an appropriate cause of death. We need to correct this. And so we go back and forth on that issue. So we spoke, some member of the panel talked about educating the public. So this is part of the education too, in terms of the clinical side of the coin.
Yeah, and our vital records agencies do a lot of outreach. Their field staff, most of the jurisdictions have staff that are dedicated to go out and educate people on a rotating every day, ongoing basis, just going around to every hospital, every funeral home, building that relationship, making sure they understand the importance and respect the data. But that job really shouldn't just fall to vital records alone. That's the job of medical examiners and coroners and physicians to make sure that data is correct. And I'm not sure it's just a different perspective, right? But it's one that really challenges us daily on the quality of the data side. Yes?
Hi, so just kind of building on that, what are the efforts to improve maybe medical education and capturing these students before, while they're in medical school to kind of, be more thoughtful about how important these statistics are to the data and to improving outcomes in the future, as opposed to, I think the work that you're doing now is important in terms of having these rotating groups kind of going in and providing education, but can we capture those or start increasing awareness earlier on and infuse it into the curriculum?
Yeah, this is something that when we get together as vital records professionals, we talk about all the time. It's on our wish list. It's high on our wish list. And I think just getting the attention of the physicians' organizations is a challenge for us. There are lots of things going on in their world, and vital records seems like a very low on the priority for them. So I think there are current educations, especially in the residency programs for physicians, especially if they're doing maternal child, obstetrics, gynecology, but it's certainly not something that is pervasive across all physicians, and physicians are about preserving life and not about death, so it's a tricky thing to be teaching them. But I'll pass it on because I'm sure you guys have some experience.
Yeah, in our training program, we start at the resident level that they do fill out death certificates, that they're the first line, and we oversee it as sort of a way of, introducing early on the elements that are part of adult life, even just as a trainee. But for sure, it's not persistent, and not all institutions do that, and that's where I think sort of there has to be some advocacy for that on a higher level with the organizations that govern the components of residency training.
Yeah. Yeah, we have toolkits, and we make them available to all of our member jurisdictions, and their field staff use them and give them to the physicians, especially the local physicians associations in their states, but it doesn't guarantee that they get used. Lou, did either of you want to add anything?
I just want to, we're having difficulty getting into those medical institutions. I know there's a lot on their plate, but every now and then I'll get in on a luncheon, please, and they're very anxious. They're like, hey, can we just tell you, like, if somebody's in hospice? Well, yeah, but okay, please just do all the other stuff. So there's not an interest by the physicians. It's getting through in the medical institutions because they have so many things we want to teach them. And I think the other unfortunate thing in trying to get these broader statistical pieces of information and the need for them through, we're so compartmentalized in how we train our physicians. I'm interested in dealing with a particular organ system, and that's all they talk about, that's all they work through. So getting just that higher level public responsibility is kind of fallen by the wayside, I think, unfortunately, in some areas.
Anything else?
My name is Ms. Added on to what Shauna said about systems and costs. For us, if you're advocating for funding, for us in the district, we need funding to get those systems to maintain them, because we live off what we earn, what we generate from those records. So if we don't have money, we can't build those systems. And so I just want to put that out there as a takeaway for us. Maybe other jurisdictions may not have that, but for us, that electronic systems. And then we're talking about in the future interfacing with So that's going to be another pot of money or another bucket of money that I know that a lot of jurisdictions may not have money to do.
Right.
So that's just one thing out there. And then, you know, in terms of the general approach, this is wonderful and it's getting out there because we do, by legislation, have a maternal mortality review committee by statute. And we had a kickoff but that's under our Office of Chief Medical Examiner, and that's not fully functioning the way it should be. So we just had a hearing about maternal mortality. So what came to the table that we're trying to have them broaden is to approach this from a perinatal health rather than a maternal mortality. And then the definition seems to be interchangeable. Maternal health versus pregnancy related, because what was presented here by definition is pregnancy related. So when people are not on the same, in terms of using the same definition,
right.
We're reporting maternal mortality to be everything but within 42 days. And then you're using, and other people here are using maternal mortality to include everything up to a year. So I think we need to be careful about how we use the definition, because then when what's reported, people are not reading what's in the byline under that box.
Right.
They're looking at the numbers, the title, and then they're saying, oh my gosh, we have this crisis here, and I'm not saying that, you know, to Devin's point, that reporting is 100%
Accurate.
the way we were. We needed to be. But I just want to put that out there, because a lot of times I have to explain when the media calls or other people call why is such and such reporting the numbers that way, but you're reporting this way. And I'm saying, I'm going by definition of CPC, WHO, this is what they say, this is what they say. So I just want to put that out there.
That's a challenge shared by many jurisdictions. Having a media call in and say, we've seen this number, and then having our vital records agency having to kind of back up and explain statistics 101, you know, which they don't want to hear, right? So it's important to be comparing apples to apples, and explaining that is always a challenge.
If I could address just a little bit about the funding. I know all of you have probably had to get your birth certificate, particularly to get your real ID, your driver's license, et cetera. We get our funding through the sales of these pieces of paper for you to be able to go and do your business. We're trying to evolve away. Eventually those pieces of paper will go away, but that's what we live off of. We sell those. We're not being very successful at being able to recoup the cost of selling our data or getting our data or sharing our data, however we deal with it, through electronic processes. We really don't get the return on investment. So what's really unfair that a lot of us have concluded is that widow or widower that has to come in, they need 15 copies of a death certificate for their loved one to settle estates, that we have to raise their individual price for a record to meet the cost to provide this data to do our business. And that's unfair. So we are working hard to try to find ways to recoup some of our costs through the sharing of our data through electronic methods now. I mean, I think there are ways to share that burden across the myriad number of researchers, users, federal agencies, et cetera. So our future is going to be looking toward finding ways to recoup those costs. So you may be hearing more about that at some point, but I just don't think it's very fair for people needing these records to have to foot the bill for other groups that are using the data and get funded. That you can't tell me there's not a line for data in a grant application. It doesn't make its way back to the Vital Records Office. Very rarely do we see that funding. So it's been a mixed bag for us to be able to continue to operate and be able to invest in our systems.
Well, I'm being given the high sign. So thank you very, very much for coming today. Please contact us with more questions. Be happy to talk to you. Thanks again.